Dr. Merin, Nana, Raju. Yep. Please come on the dais and you can start your presentation.
Good afternoon, everybody. Today, the topic of discussion will be on optic nerve sheath fenestration for vision loss in cerebral venous thrombosis and outcome case series. The aim of the study was to evaluate outcomes in cerebral sinus thrombosis associated vision loss, those patients who were treated with optic nerve sheath fenestration. So, cerebral venous thrombosis presents with headaches, focal deficit seizures, encephalopathy, or intracranial hypertension-like syndrome. Vision loss is a dreaded complication which occurs in 13 to 30% of patients. The mechanism for visual impairment is complicated and includes primary venous ischemia and secondary intracranial hypertension, which causes post-papilledema optic nerve dysfunction. Medical treatment for CVT includes anticoagulants, ICP lowering medications, and repeated lumbar puncture, which effectively reduce CVT-associated mortality. CSF shunt surgery, mainly the thecoperitoneal shunt, is often performed in CVT patients with persisting and severe vision loss and headache, symptoms of increased intracranial tension despite the best medical treatment. Optic nerve sheath fenestration, which involves cutting slits or windows in optic nerve sheath to allow CSF to escape, is the other surgical procedure for protecting the visual function of patients with IIH. The need for this study is because the mechanism of vision loss is complex in CVT, and it's unclear whether ONSF could help improve visual impairment in CVT. There is limited reports in literature of the effectiveness of ONSF in improving or preserving the baseline visual acuity in CVT patients. Therefore, an evaluation of ONSF efficacy and safety for vision loss in CVT is much required. The methodology in the study was a retrospective case review over the period of January 2023 to December 2024, and patients who had CVT with vision loss and no response to the best medical management, and those who underwent surgery for progressive vision loss due to CVT were included, whereas the patients with CVT without vision loss and those who improved with adequate medical management were excluded. The age group included from 22 to 33. These patients were referred with progressive vision loss was referred from neurology, and detailed ocular evaluation was done, which included visual acuity, color vision, perimetry, B-scan ONST, and the patients underwent these tests post-surgery also. The results include the gender distribution for the study was equally distributed among male and female, and the cause include in 50% of the cases polycythemia vera, and another 25% raised ICT syndrome, and other group anti-RNPSM antibody. The results showed that out of the 4 patients who underwent the surgery, 2 patients showed significant improvement in visual acuity, 1 patient showed improvement in the perimetry fields, and whereas the vision remained status quo for 1. These are the images showing the preoperative and postoperative B-scan, which show the decrease in ONST values, and the fundus photograph, which shows decrease in the grade of papilledema. So the best visual improvement occurred in 1 patient with mainly vision field loss, which was of acute onset, and marginal improvement of status quo vision occurred in the other 3. So coming to discussion, the visual outcome following ONSF in patient with vision loss due to CVT was poor in the small series of patients. The pathophysiology of vision loss in CVT is complex, and it includes both primary venous ischemia and it occurs secondary to intracranial hypertension. So ONSF, by facilitating the drainage of CSF, mainly targets the compression of optic nerve secondary to intracranial hypertension and not the venous ischemia, which is caused by CVT. The postoperative substantial reduction in papilledema severity and ONST supports the theory that visual loss in CVT is multifactorial and not only due to the intracranial hypertension. In the 2 patients who showed minimal or no improvement in visual acuity despite the reduction of papilledema and ONST, the visual loss was chronic. The chronicity of the raised ICP is most likely to have caused an irreversible optic nerve fiber damage, which led to the poor improvement in visual acuity despite the anatomical success of the procedure. Therefore, the patient with CVT should undergo frequent ophthalmological evaluation to detect early vision loss and institution of early treatment when vision loss is detected. In conclusion, the overall visual outcome was poor despite aggressive medical therapy and surgical intervention in patients with visual loss due to CVT. Regular monitoring of the visual function to detect early vision loss will reduce the burden of severe irreversible vision loss in CVT. The limitations in the study included the limited number of patients, as vision loss in CVT is not very common. More prospective studies with larger cohort is required. These are my references. Thank you.
2 things are very important. the optic neuro. One is the blood supply of the optic neuro. According to Surjit Hare, who did a revolution in the optic neuro blood supply. You know, optic nerve is supplied by posterior artery.
Yes, sir.
It's a branch of ophthalmic artery. It arises from the first digit of intercarotid artery. According to Swansea Carey, posterior artery, after supplying the disc, has a segmental distribution, the choroid and the epiphytic choroid. So, if there's a deficiency in the blood supply, that doesn't produce changes only in the choroid, but in the epiphytic choroid, characterized by the covenant optic nerve. Filling of the blood in the posterior artery depends upon the difference of the intraocular pressure and the perforation pressure at the optic nerve. Greater the difference, better. So when the intraocular pressure goes down, pressure goes better filling. That gives us the scenario of the optic neuropathy. The second question is the CSF circulation. 70% of the CSF is produced by the arachnoid villi of the choroidal plexus in the lateral ventricle. From the lateral ventricle comes to third ventricle through the foramen of Monro. From the third ventricle comes to the fourth ventricle through the aqueous cilius, and then in the venous sinuses by foramen of Lichka-Meninges. So you have to know the basically. So there's a difference between an MS and the FRCS. Our DNB MS will be very good, but it lacks the basic sinuses. I did FRCS part 1. At the age of 70 or 68 years, I had to read. And when you go, that's why I remember a little bit of this thing, because when I was in the outside, they don't consider our MS and the DNB. They make us specialists. They're not wrong also, they're not right also. So I was made a consultant, and the people objected that Dr. Gohar has got only MS. But the director was better, he made me a shoot consultant, but then I had to do the FRCS, which I did, very difficult. There's a negative marking in the Edinburgh. That's why you see that you have to know the basic science. Your presentation is very good. Thank you very much.
So, the optic nerve sheath fenestration was done by which route?
Medial conjunctival route, ma'am.
Medial and?
Medial conjunctival peritomy was done. Medial canthotomy approach was done.
Have you just got through the Dr. A.K. Grover's references? He has done a lot of work on this optic nerve. This. You know Dr. Ashok Kumar Grover?
Yes, sir.
What is the, after how many, what is the period of between diagnosis and doing the fenestration? Average time?
Ma'am, ideally as soon as possible, because anyway the patient is already on the maximum medical therapy, and more time we lose, there is more chance
in
of.
your study, when was it done?
Within a week, ma'am. Within a week.
But how will you know whether there is a response with maximum medical therapy? Did you find out within a week? You said after maximum medical therapy, if not responding, then the
Yes.
fenestration was done.
Yes, ma'am. So at the time the patient was referred to us, ma'am, the patient was already on the maximum possible, like acetazolamide 2 gram per day, already on IV mannitol TID.
Since
By the time they presented to us, ma'am. So
I mean, based on this, when did the patient present and when did you take him for the fenestration? What was the time gap? Considering anywhere he might have visited before you. So what was the time from onset of symptoms or onset of clinical signs to optic nerve sheath
But as she has
presentation?
correctly said, it is a kind of an emergency. It should be done as early as possible.
When did you do in your study? In these 5 subjects, what was the mean time from presenting
within like
to
a
the
week,
first
week or
doctor?
2 weeks, ma'am, after the patient presented to us.
No, to you, but you are saying
may
he was
have-
already on therapy before that.
he may have been on therapy since 1 year.
Okay, yes, ma'am.
So you didn't analyze that part, that when was the patient diagnosed and started on medical treatment anywhere?
Less than 6 months, ma'am, not more than 6
So it
months.
was almost 6 months
Almost 6
gap.
months.
And were they getting anything for the venous sinus thrombosis also? You mentioned acetazolamide mannitol. but
They were
anything
on
else?
this anticoagulants, ma'am, already.
Which ones usually? What is given in these cases? Was it started to them, or were they only on the ICT lowering agents?
I think these four were only on ICP lowering, ma'am, not on
So if you are
antiangiogenic.
not treating the cause for 6 months, you cannot expect a response when you
response.
are taking them. Okay. Thank
Thank
you.
you.